bipolar 1 or bipolar 2. And in bipolar 1, essentially, we should get a history of a manic episode with or without the presence of a depressive episode. And in bipolar 2, there should be a history of depression, and we should be able to elicit a history of hypomania in the history. Now, these are discrete episodic illnesses, but at times what happens is the symptom doesn't reach the threshold criteria. So we get sub-threshold mood symptoms, which can pervade over a period of time, that we call as a pervasive mood disorder. And the pervasive mood disorders includes dysthymia and cyclothymia. The presentation can be at times little atypical or tricky with in affective disorder, in which the presentation can be mixed features. Now, let us try to understand the two construct based on this nice picture. If we see uh, uh, the uh, the unipolar section, the depression can begin as a single episode, and the mean length of the depressive episode can vary from 8 months to 10 months. It can end, it can start as a single episode and end. It can recur as we see, and if it recurs, it becomes a recurrent depressive disorder. Now, if we look, there are two important things is how the onset has been. Has it been an acute onset or it has been an insidious onset? What has been the progression? What is the cycle length? And what is the interepisodic state? Is the interepisodic state, there are some deficits. So if there are interepisodic deficits, we call this as RDD, recurrent depressive disorder with interepisodic deficits. Or else at times the deficits, it's difficult to delineate the deficits from the acute episode. And at times it can appear as a very chronic kind of a course with fluctuating severity. At times, it may not meet the threshold criteria to call it as a depressive episode. So these kind of presentations can be there. But when we look at the other side, that is the bipolar depression, in bipolar depression, essentially, we should be able to elicit a history of a mania or a hypomania in the history. And if you see the symptom pattern or the cycle pattern, the onset is very usually acute and the progression is very sharp and very fast. And if you compare the mean episode length between unipolar and bipolar, you can distinctly see that the bipolar depression, the length of the episodes are less, they're shorter in duration, and the severity is more marked. So broadly, with this particular diagram, we go ahead to the next slides. Now, what can be the what can be the reasons for the underdiagnosis of bipolarity? Now, before that, let us go to the statistics. Most of the patients who present with either unipolar depression or bipolar depression, the essential initial presentation is a depressive episode. So in majority of the 40 to 50% of the patients with bipolar depression is initially misdiagnosed, and the default diagnosis is unipolar depression. And subsequently, when we go ahead, like probing for the course, the diagnosis can change to bipolar depression unless proved otherwise. So an essential, very interesting comment had come in one of the journals, one of the papers in Journal of Affective Disorder, that it takes about 10 years and more than 4 psychiatrists to confirm an accurate diagnosis of bipolar depression. And if you compare between bipolar 1 and bipolar 2 is much more missed than bipolar 1. Now let us, in the next slide, let us try to see what can be the reasons for the same. Why this underdiagnosis of bipolar depression? Now, essentially, if we see that eliciting a diagnosis of bipolar depression depends on the key element is from the patient or from the informant, we should be able to get a clear account of an episode of mania or a hypomania in the history. There lies a problem where there can be memory or recall biases in eliciting the history. Number two is when we look at probe the history, we throw more light on trying to find out what can be the mood changes. So mood changes we give more importance than getting the history of overactivity as a STEM criteria. So often the patient, particularly in context of hypomania, it becomes a really tough task to clearly elicit a discrete period of hypomania. At times, uh, like after a patient has come out of a depressive phase into a phase of normalcy, he feels well, he feels relaxed, he feels joy, he feels hopeful. Now, dissecting that normalcy from hypomania becomes a really challenging task because the threshold criteria for hypomania is also variable. Like for ICD and DSM, we have some fixed criteria, but if we go to other researchers like Squarts et al. And other, the duration criteria and the symptom criteria for hypomania is variable. So depending on all these variability, it becomes really challenging for us on the first visit, on the first go, to diagnose somebody is having presenting with depression, to clearly tell that it is unipolar depression or a bipolar depression. So this needs a very careful, clinical, skillful interview by the psychiatrist. Now, as a consequence, what happens is if we are underdiagnosing or misdiagnosing the entity, so there occurs an increased risk of a manic switch. There can be mixed episode, or the the picture can be a mixed presentation. There can be accelerated cycling, or that there can be introduction of rapid cycling because of inadvertent use of antidepressant. The issue becomes more problematic because we are not going in the current treatment lines. So there is suboptimal resolution of symptoms causing more debility and pain and suffering in the individual. And coming to the consequences, that the risk of substance use increases more with bipolar depression. And most important issue is suicidality. If we compare the statistics between bipolar depression and unipolar depression, you can see that in bipolar depression, there is a threefold increase in the risk of suicidal attempt as compared to unipolar depression. So if you are underdiagnosing bipolar depression, you are basically underestimating the suicidal risk. And the lifetime risk of suicidal attempts becomes much more higher unless early identification intervention is done. So that is why this topic is of utmost importance. Like from the first visit only, how can we do the clinical dissection in a proper way? Now, before that, let us try to understand these two constructs, that is bipolar depression and this unipolar depression. Are they same? Are they same? Or they're distinct entities? So bipolarity means that there is mania with or without presence of depression. So this particular school of thought, they regard mania and depression as the same end, the ends of the same disorder. Basically, they're poles, two different distinct poles of the same disorder. So depression and bipolar are almost considered the same, regardless of the presence of lifetime presence of mania. Why? Why? Because there is like looking at the neurobiology and the course, both the unipolar depression and the bipolar depression almost have got similar neurobiology and similar kind of courses. Coming to the neuroanatomical correlates, that what does the functional neuroimaging studies tell? That there is increased activation in the amygdala and the limbic cortex in both these disorders. So the functional neuroimaging also suggests that similar findings in context to exposure to sad stimulus. Now coming to the changes in the monoamines and their metabolites and their changes to different challenge tests is also the findings are replicable across the two constructs. So basically, if we look at the neurobiology part, the two things, the two entities appears as the same, the extreme ends of a same continuum only. So based on this, Klarman had proposed a concept of spectrum. So subsequently, Akiskal and the colleagues proposed a soft bipolar spectrum, where we know about bipolar 1, where there has to be a episode of mania with or without depression. Bipolar 2, where we have a depression with the history of hypomania. Bipolar 2.5, where there is a underlying cyclothymia. On top of that, there is a depressive episode, or there can be bipolar 3, where there can be pharmacological induced or antidepressant induced switch. So basically, this spectrum concept goes with the first line. Now, the second line of thought is whether they are distinct. Yes, definitely. They are difference. There is a difference in their course. There is a difference in the symptomatology or phenomenology of presentation, which is the key thing in my presentation today, which I'm going to cover in the next slides. There is a difference in the mood variability of the individual between the two constructs, and the treatment approaches and the response to the different treatment approaches also differ. So now let us go to the differences in the course between bipolar depression and unipolar depression. If we remember the first slide, let us go to different variables and go for a comparison. These next three slides are going to be very important in context to the theme of my presentation. The age of onset in bipolar depression is usually younger, that is around 6 years younger as compared to the onset of unipolar depression. And unipolar depression can present across all ages. Usually, if bipolar depression, the onset is usually fast, very fast, abrupt or acute onset as compared to unipolar depression, and the progression is faster, and it reaches very high severity in a very short period of time. And coming to the mean length of the episode, as was seen in the first that graph, the duration of the episode is lesser, usually 4 to 6 months, as compared to unipolar depression, where the mean length of the episode is relatively longer, around 8 to 10 months. Severity is this: the presentation of bipolar depression is much more severe, and as compared to unipolar depression, the frequency of episodes of further recurrences are more with bipolar depression. Coming to the core clinical features, if we see, how will you distinguish if the patient comes to us for the first time? If Dr. Shantanu can recollect, we had two patients who had come from Medinipur region, a young male who had a family history of mood disorder in a sister. That that child was around 14 years of age, who had come in a state of severe psychomotor retardation, was extremely withdrawn, was sleeping the whole day. There were multiple episodes of suicidal attempt in the over a period of 1 week. So we were confused, like whether there are any predictors of bipolarity or there are hinters of bipolarity. So with this example, we will throw lights on how we can dissect between the two entities. In bipolar depression, the patients, as I told you with an example, they are more withdrawn and retarded, and as compared to unipolar depression, where they are mentally and physically more active as compared to bipolar depression. The anxiety symptoms and the somatic complaints are much less, but in unipolar, these anxiety symptoms, anger, agitation, they are much more. Mood, the patient will be more withdrawn and retarded. There can be evidence of mood lability in bipolar depression. The patient will report of severe anhedonia or a lack of drive to do anything with bipolar depression. And the psychomotor activity will be grossly reduced. So there will be almost a kind of mental and physical freezing in bipolar depression. However, the melancholic symptoms or the somatic symptoms will be less as compared in bipolar depression as compared to unipolar depression. And among all of these features, mood lability is the most specific predictor for bipolarity. Along with that, bipolar depression might present with a set of atypical vegetative and psychomotor symptoms, like they will be sleeping more. Okay, so there will be hypersomnia, hyperphagia, high rejection sensitivity, and laden paralysis is a description where they feel that the limbs are heavy like a block of log. But as compared to in unipolar depression, we will have typical vegetative symptoms, like there will be initial insomnia, weight loss will be more, loss of libido will be more. Again, coming to the treatment responses, there will be poor response to antidepressants and favorable response to lithium and antiepileptic drugs or mood stabilizers in context of bipolar depression, whereas unipolar depression have a relatively better response to antidepressants. Suicidal risk and substance use risk is higher in bipolar depression as compared to unipolar depression. Coming to the differences in the psychosocial variables, usually with patients with bipolar depression, temperamentally, they have got higher scores for extroversion and novelty seeking, and they are less judgmental as compared to unipolar depression. And coming to the family history, we will get a family history of family loading in both the entities, but there is something called a bipolar loading in the family. A bipolar loading is a concept where in the first degree relative you can get 3 or more of the first degree relative of the proband to be suffering from bipolarity, or else in the 3 generation pedigree you will get a family history of bipolarity. So this particular family loading of bipolarity is more prevalent in bipolar depression as compared to unipolar depression. And negative life events and poor social support, both the entities are at similar risk. Now, this is a kind of a summary slide where we will just recollect what we have told in the last few minutes. So, in bipolar depression, there has to be a history of mania or hypomania. Temperamentally, bipolarity, the patient will have cyclothymic temperament, whereas in unipolar, they will have dysthymia. Sex ratio is again unequal in case of unipolar depression, with more of female prevalence as compared to male. The age of onset is usually early, whereas in unipolar depression, they can occur across ages. The onset usually abrupt. The severity is fast progression. The more of psychotic symptoms are evident. More number of psychomotor activity will be more. Retardation will be more evident as compared to agitation. Whereas in unipolar depression, the reverse will be there. More of agitation might be evident. The biological function again will be reversed. There will be more of hypersomnia in bipolar depression as compared to unipolar depression. And looking at the family history, there will be a family loading of bipolarity and unipolarity, but the bipolarity loading will be more in bipolar depression as compared to unipolar. So what a clinician must know is the predictors of bipolarity and what are the sensitive tools by which we can screen them. So there can be some repetition points in that, but these are some indicators of bipolarity. So suppose I give that example of the child who presented to us to our IPD with some symptoms. If we go and see, usually the onset was early. The mood variability was more. The patient usually reports of a very retarded mood. At times, you can see some mood fluctuations, very apparent mood fluctuations can be there, although they can be for a transient period of time. You can get atypical features, mainly atypicality in the biological functions, hypersomnia, psychomotor retardation, severe anhedonia, lack of drive to do anything. And you can get some hinters, like there can be seasonal mood changes and they're usually postpartum onset. These are predictors. Atypical, atypicality in the presentation of the depression, atypicality in the reactivity of the mood to emotional laden cues. Along with that, strong indicators of psychotic symptoms. There is a family history of bipolarity with a history of pharmacological induced hypomania or switch. Or if you see that the episodes are very brief and there is a rapid resolution of symptoms and they're occurring very frequently, these are usually indicators that we are dealing with more of bipolar depression. Now, this is a very interesting rule of 3, hinting at soft bipolarity. So, according to this interesting proposition, if the patient has got 3 major depressive episodes with 3 failed antidepressants, with 3 first degree relatives with affective illness, and 3 generation family pedigree positive for family illness, for affective illness. Along with that, there has 3 failed marriages. There is a triad of 3 personality distortions, in the sense there will be histrionicity, psychopathic personality, and borderline diagnosis in the premorbidly. And there can be 3 substance of abuse, 3 impulse discontrol disorder, and simultaneously dating of 3 individuals. So this is a very interesting rule of 3 which indicates a hint at possibility of a soft bipolarity. So identifying at-risk patient will involve a very careful and skillful clinical interview involving the patient and the family members and significant others who are associated with the patients in the initial evaluation. So we have to keep our minds open for the possibility of history of hypomania or mania in the course throughout the course, and the focus should be more on hyperactivity over mood changes. Usually we ask in the history that has there been any change of distinct mood changes, but uh, I don't tell that we should not focus. Actually, the focus should be on both. Is there any observable change in the degree of hyperactivity or any observable subjective change in the mood state, which has sustained over a period of time, which was observable and recognizable by both the patient as well as the caregivers. Probe for a family history of bipolarity and evaluate for a response to past antidepressants. And then we can administer some bipolar disorder screening instruments. Now, these are some interesting screening instruments which can help us aid diagnose in the diagnosis of bipolar depression. This is the mood disorder questionnaire. If you see, there are 3 items. The item 1 contains around 13 questions, out of which the patient qualifies for more than 7 questions. And in the second response, if the patient gives a yes response, then the chances that the patient is having bipolarity is more. We are dealing with more of a bipolar depression. This is something, another interesting ratings tool, that is the bipolar depression rating scale. Many items you can see as an overlap with HDRS, but the changes you can see is like most of the questions are framed around the depressive to elicit history regarding the depressive symptoms. Uh, Item 16 onwards, the next 4 items from 16, 17, 18, 19, and 20, they are items which are designed to tap mixed features only. So each item has got 3 scores, and preferably a person can get a maximum score of 60. 20 items are there, so 60 is the maximum score. The more the score, the higher we are dealing with the patient with bipolar depression. Now, this is something, another interesting scale, that is the bipolar spectrum disorder scale, where if the person is scoring, it's almost a kind of a narrative in which the patient has to identify whether he's fulfilling for certain narratives. And if at the whole score is more than 13, then there is this is the optimal threshold for a positive diagnosis of a possible bipolar spectrum in the patient. This is something similar to what we have spoken, is something that is called as a bipolarity index, where this index, we try to look across 5 domains or 5 dimensions. Basically, we try to see or assess the kind of episodes the person had over the entire life course. What were the presentations of hypomania or mania? What was the age of onset of the presentation or the first mood presentations? How the course of illness ran? And what was the response to the different medications used? And what was the family history of mood and substance use problem? So this is something that is called as a bipolarity index. So I gave you a brief overview of the challenges while we face when a patient presents to us with depression. What can be the doubts that can creep in our mind? What are the things which we have to keep in mind as a sensitive clinician? What are the things we have to focus during the interview? And during the process of interrogation, what are the things we have to closely and neatly dissect in order to establish correctly that we are dealing with bipolar depression or unipolar depression, because our decision ultimately has got a strong bearing on the patient's overall course, response to treatment, and prognosis. So eliciting the history of mania or hypomania is most important. And bipolar disorder, especially bipolar 2, is often underdiagnosed. So in our interview, the 2 important determinants while we are eliciting the history is we have to look for eliciting the exact mood variability of the individual, which can be subjectively and objectively confirmed, as well as importance has also to be given on the history of hyperactivity or overactivity. The predictors of bipolarity should always be probed, whether there is seasonal affective features, whether there is postpartum onset, whether there is atypicality in the presentation. And this can further be facilitated by the use of validated screening tools. So with this, I come to the end of my presentation. Thank you all for a patient listening, and I'm open to take up any questions, clarification, or comments.
Thank you very much, Dr. Mishra. And as expected, it was an extremely informative and easy to understand talk. And I'm hoping that the participants will have certain questions that they want to address to you.
With the permission of the chairpersons, we can take up the questions in the chat box, and at the end of the three presentations, we can take all the questions at the end as a panel, kind of panel discussions where we can get inputs from others as well.
I agree with that, because we have a Q&A session by Dr. Santanu at 8 o'clock, 8 to 15.
Yeah. Sure, sure.
I think that would be
That's
better.
a good idea. Yes, sir, that's right.
बाद में बात करेंगे, अभी मीटिंग में
unmute yourself.
I call you later.
No, you are muted. You have to unmute yourself.
Yeah, Dr. Narasimhan. Okay. So it was a wonderful talk by Dr. B.R. Mishra, sir. Without much delay, we would move on to our next speaker, Professor Dr. Muralidharan Kesavan, sir. Sir would be speaking on the management updates and how it translates into clinical bedside practice in current day-to-day psychiatric practice. We have with us chairpersons, Dr. T. Sudhir, sir, and Dr. Sanjay Kumar Munda, sir. So Dr. T. Sudhir, sir, is a current consultant psychiatrist in Bokaro, Jharkhand. Sir did his MBBS in 1979 from MKCG Medical College, Berhampur, Odisha. And subsequently, he did his DPM in 1990 from Christian Medical College, Vellore. Sir worked as an SR in psychiatry in CIP Ranchi from 1990 to 1992. And thereafter, he worked as a psychiatrist in Bokaro General Hospital, from where he retired from the post of Joint Director in 2014, and now is practicing as a consulting psychiatrist in the town of Bokaro in Jharkhand. Sir has also held multiple important and prestigious posts, was an honorary secretary of Indian Medical Association in Bokaro Steel City, and also held the post of honorary secretary and president of IPS Jharkhand State Branch, has been a direct council member of IPS EC from 2006 to 2008, and has been the president also in IPS Eastern Zone in 2013 and 14. Our next chairperson for this talk is Dr. Sanjay Kumar Munda, sir. Sir is currently working as an associate professor of psychiatry and also the in charge of SS Raju Center for Addiction Psychiatry in CIP Ranchi. Sir did his MBBS from Darbhanga Medical College, Darbhanga, Bihar, and subsequently he did his DPM in psychiatry and MD psychiatry both from CIP Ranchi. His area of interest is addiction psychiatry and as well as adult psychiatry, and has a vast experience of more than 20 years in psychiatry, the field of psychiatry and mental health. He has to his credit more than 20 publications in both national and international journals, and has been a nodal officer for drug addiction program in CIP Ranchi under the Ministry of Health and Family Welfare, as well as the resource person for capacity building and harm reduction programs in the field of addiction psychiatry. He has been a co-investigator for National Survey for Pattern and Extent of Substance Use in India. I think that was in 2019 that it came. It was conducted by AIIMS Delhi, and has been the organizing secretary of the 17th ANSIPS that was in 2018 at CIP Ranchi. Over to you, Chairperson, sir, to introduce the speaker, and we'll move on to the talk by Professor Muralidharan, sir. Over to you, Chairpersons.
Yeah, Sanjay, you can. Before I ask Sanjay to
yes, sir. Good
introduce
evening,
speaker,
sir.
I would first like to thank everyone for inviting us and making us chairpersons. And before we go down to, I'd like to thank Dr. Mishra for a brilliant exposition on the topic. It clarified many of our doubts. I won't take up much of time now. I will discuss things during the question and answer. I think Sanjay can introduce Dr. Muralidharan, and we can proceed with the session. I don't want to waste any time here. Please, Sanjay.
Yeah, thank you, sir. First of all, I really thank the Department of Psychiatry, AIIMS Deoghar, Professor Vashne, Shantanu, and Narsimha for giving me this opportunity. And I take privilege in introducing Professor Dr. Muralidharan Kesavan, who is a medical superintendent and professor of psychiatry and chairperson and psychotherapy program at NIMHANS Bengaluru. And he is a medical graduate from Bangalore Medical College, and he did his MD from NIMHANS. Then he is also has done MBA in hospital administration from Madurai Kamra University, uh, and he has been faculty at NIMHANS since 2007. So he has a vast experience, uh, and he is visiting professorship with Mood Disorder Center of Excellence, Vancouver, Canada, from 2012 to 2013. And he is also Life Fellow of Indian Psychiatric Society and IPS Karnataka chapter and Society for Bipolar Disorder India. And he is also a member of Neuromodulation Society of India. We know that Dr. Muralidharan is quite a known uh, person in the fraternity of psychiatry, and is known for his works on bipolar disorder, mood disorders, and neuromodulations. So, and he has in his credits various awards like Asian Young Psychiatric Award, WFS BP Award for Young Investigator, RSA Young Investigator Award, Samuel Gerson Award, Professor Raghuram Distinguished Young Teacher Award of IPS Karnataka chapter in 2021, and he has in more than 125 peer-reviewed international journal publications. And we know that he is a great academician and researcher, and after a wonderful deliberation by Dr. Biswaranjan Mishra, I think he will lead us through how bipolar depression, the challenge of if you resolve the challenge of diagnosis and all, how to proceed with the treatment. So over to Dr. Muralidharan Kesavan for his deliberation, please.
Thank you so much for introducing me, Dr. Sanjay, and thank you so much, Dr. Sudhir. I hope my slides are visible.
Yes,
Visible,
sir.
sir.
Yeah.
I think it has.
And I'm audible too.
Yes, sir.
Yes, sir.
All right, wonderful. Thank you so much. Okay. So, yeah, so thank you for giving me this opportunity to talk about a topic that is very close to me, management of bipolar depression. So I remember when I would talk about bipolar depression about 12, 13 years ago, I would get very odd looks. And here we have an entire CME that has been dedicated to bipolar depression. So I must really congratulate the organizers. At the outset, let me say that I have no conflict of interest to disclose, and I'd like to take this opportunity to thank my mentor, Professor Lakshmi Yatham, for all the guidance that I have received in the area of bipolar disorders, and of course the organizing committee and the IPS Jharkhand state branch for this wonderful opportunity. So this is the outline of my presentation. I'll start with a few slides on setting the context, some challenges in management, mostly because Dr. Mishra has given a wonderful presentation on challenges in diagnosis, a little bit about the evidence, advances, a few slides on bipolar depression, and a summary slide. Now, this is my favorite slide, which I'd like to talk about in all my presentations. So, bipolar disorder has been the Rahul Dravid of severe mental disorders compared to the Sachin Tendulkar, who is the schizophrenia of severe mental disorders. So, as severe as debilitating, but has received much less attention, which is why it gives me a lot of pleasure when I see people organizing CMEs on bipolar disorder. So, to start off with a quote from Charles Dickens, A Tale of Two Cities. If you're aware, these are the starting lines of this wonderful book. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief, it was the epoch of incredulity. It was a season of light, it was a season of darkness, and it was a spring of hope, it was a winter of despair. And it is this that we'll be talking about today, how to manage the winter of despair, that is bipolar depression. So we all know that bipolar disorder is a fairly prevalent severe mental illness. WHO pegs it at 2.4% as the lifetime prevalence of bipolar disorder, and our National Mental Health Survey said it's about 2.8%. And the global burden of disease study puts it at 10th among all diseases in terms of the million years lost to disability. And importantly, the treatment gap for bipolar disorders in India is greater than 70%, which means that only 30% of the people with bipolar disorder have accessibility to treatment, while 70 don't have. So that's a very serious problem. What are the challenges in the treatment of bipolar disorder? One, you have different polarity of episodes. There's incomplete recovery, inter-episode symptoms, breakthrough episodes, there's cognitive deficits. You have a disorder where you have psychotic symptoms that come within episodes. The outcomes tend to be poor and there's significant comorbidity. So there are so many things that one has to manage in terms of bipolar disorder itself. And add to that, you have various phases of treatment. For example, in the acute phase, you would employ a kind of management plan that's quite different from what you would be employing in the maintenance and prophylactic phase. So the continuation phase probably marks a transition between the acute phase and the maintenance phase. You're probably taking off some medications and then you're consolidating the treatment on other medications. And this is what I'd like to focus on a little bit in the management a little bit. So what are the challenges in the diagnosis and management of bipolar depression? Well, start with the case vignette just for illustration. So you have a 32-year-old married lady with 2 children, comes to us with 4 months history of acute onset of pervasive low mood, crying spells, loss of interest, feeling tired most of the time, frequent awakenings at night, poor quality of sleep, has some degree of psychomotor retardation, withdrawn behavior, reduced appetite, death wishes, and hearing voices saying that you're evil and you're going to die. Feelings of pessimism, occasional suicidal thoughts, but no suicidal attempts. The history reveals past history of one manic episode lasting for about 2 months, and the last episode occurred about 2 years ago. And this patient has in the past received treatment with quetiapine 600 milligrams per day, lithium 900 milligrams per day, and stopped about a year ago. I'm going to come back to this slide a little later. So, as we all know, I wish I could ask questions, but I can't. So I'm going to say that the diagnosis is bipolar disorder, severe depression with psychotic symptoms. So this is what we're talking about. So when you have the history of a past manic episode, the diagnosis is fairly clear, and you make a diagnosis of bipolar depression. Irrespective of what kind of bipolarity may be there, whether it's bipolar 1, bipolar 2, cyclothymia, or mixed affective states, you find that the depression can be quite disabling, can be quite moderate to severe. We also need to remember that in patients with bipolar disorder, especially in Asian countries and in the Indian context, while we know that there is the predominance of manic episodes, the amount of time spent in depression tends to be much more. Like just for example, let's say a patient has had 4 manic episodes, each lasting 1 month, and 1 bipolar depression episode lasting about 9 months. You know that the time spent in depression is far, far greater, even though the number of manic episodes may be much more. So while we may differ from the data that is present internationally in terms of the course of bipolar disorder, both abroad as well as in India, we can safely say that the time spent in depression is fairly high, which is why it's important for us to have adequate treatment for this condition. So what are the clinical challenges? I think Dr. Mishra mentioned very well. So in case there is a prior manic episode, then it's easy for us to make a diagnosis of bipolar depression. But if someone comes to us with a depressive episode, with possibility of a manic episode sometime in the future, then there are ways in which you have to distinguish unipolar from bipolar depression. So what are the challenges in the treatment of bipolar depression? So it's misdiagnosed most commonly. It predominates the course of bipolar disorder even in the Indian population. So like I said, the time spent is much more. Inter-episode depressive symptoms are very common and tend to be disabling. we have very few therapeutic options actually. If you look at guidelines, there are very few options that are available for the treatment of bipolar depression. And if we exhaust these options, then there are very few treatments that are left. So it's very important to be able to treat bipolar depression rationally and to try and use the guidelines to tailor it to the needs of our individual patients. So the first thing that, and this is more for residents who may be attending. So the first question that we decided, okay, where are we going to treat this patient? Am I going to treat this patient inpatient or outpatient? If inpatient, how long? Where am I going to admit this patient? Am I going to put this patient in an intensive care unit? Am I going to keep this patient at a general ward? Irrespective of where I treat this patient, I should also keep in mind that the Mental Health Care Act will be applicable and I need to take care of the law too, along with the patient. So that's the first decision that we have to take. So if you remember the case Vignet, with that kind of history, I would probably treat this patient as an inpatient. The next thing is, what are your targets of treatment? So more often than not, it is a syndrome of depression that we'll be treating. It's a severe depressive episode. In addition, the patient has suicidal ideation, there were psychotic symptoms and decreased sleep. So each of these have to be given importance in the acute management. And I'm sure all of us would be using a combination of an antipsychotic, a second generation antipsychotic, or a mood stabilizer, along with benzodiazepines to take care of some of these symptoms. An antipsychotic, of course, is something that we use very, very commonly in the treatment of acute bipolar depression. So what are the modes of treatment? So that is something that we're going to talk about as the talk goes on. It's important to remember that suicide is very common in bipolar depression. The standardized mortality ratio for suicide in bipolar disorder is 20 times more than the general population. So what are the risk factors for suicide in terms of the illness itself? So the risk for suicide is quite similar in bipolar 1 and bipolar 2. It's greater than in patients with severe depression with hospitalization as compared to moderate depression who are treated on an outpatient. So if you can actually rate the depression bipolar 1 or 2, whether it's severity or moderate, you can actually have some degree of assessment of suicidal risk. It's more common following hospitalization in the first 2 to 3 years of illness in the presence of mixed states with significant comorbidity and prior attempts. So again, I'm just a few risk factors for suicide, which you can. I'm basically focusing on the clinical features here. So you can see that it's more in So there are two columns here. The column on the left is who makes more attempts and what is the risk for increased likelihood of completed suicide. So you have attempts are more common in female, whereas the suicide-related deaths are more common in male. Likewise, you have predominant depressive polarity. Current episode depression is more likely to be associated with suicide risk. Other episode characteristics include mixed features, presence of rapid cycling, anxiety symptoms, psychiatric comorbidity like substance use disorder, and anxiety disorders. So these are some of the things that are associated with an increased risk of suicide. And what are the treatments that are available for suicidal risk? Now, if you can see, this table has highlighted almost all the treatments that we use in patients with bipolar depression. But in terms of the evidence that is available, you find that lithium is one of those drugs that has been consistently shown to reduce the risk of suicide attempts, as well as the ideation. And of late, ketamine has been discovered as another drug that can reduce suicidal ideation. And of course, we all know that ECT remains the gold standard when it comes to treating patients who have suicidal risk. So these are the three treatments that have a fair degree of evidence for using in patients with suicidal risk. So what do evidence and guidelines talk about? So this is a fairly recent meta-analysis which tells us about the different drugs that have been tried in bipolar depression. So in case you're not very familiar with network meta-analysis, so this is just a network plot which tells us the various drugs that have been used. The thickness of the nodes actually would indicate the number of studies that have been done in each of these drugs, and the connection between the nodes, how thick it is, would indicate whether which are the drugs that have been studied as comparators. So understandably, you would find that most of the drugs have been studied in comparison with placebo, and you find a combination of many different drugs here that have been tried in bipolar depression. To summarize them would be that you have about, you have anticonvulsants, 3 agents that have been tried, 11 antidepressants have been tried, 6 antipsychotic agents. There are trials with lithium, and you also have a total of 36 trials that have been done with 21 different pharmacological agents. So this is in brief, this is just a summary slide about what drugs have been tried. Moving on to specifics. So I'll try and refer as much as possible to some work that we have been associated with. This is a book that has been brought out by the Indian Psychiatric Society South Zone branch, and I'm sure it will be made available to all of us in the near future. So we have tried to summarize the evidence that is available for pharmacological management of bipolar disorder. Now, this is from the CANMAT guidelines 2018. As you can see, there are very few treatment options. So one is quetiapine, then you have lorazepam in combination with lithium or valproate. Then you have lorazepam monotherapy, which probably has a little less evidence than lorazepam. You have lithium, you have lamotrigine as adjunctive therapy and as monotherapy. Some of the second-line treatments include valproate, SSRIs, bupropion as adjunctive therapy, ECT, cariprazine, and olanzapine fluoxetine combination. So what we did in this particular chapter was we tried to compare what are the different guidelines that are available for treatment of bipolar depression. So we've tried to, so one is the RANSOM guidelines, the Royal Australian New Zealand College of Psychiatry guidelines. Then you have the CANMAT guidelines, and then the IPS guidelines that was published some time ago, and the British Association of Pharmacology guidelines. And I don't want to go into details about each of these guidelines, but as you can see, most of these guidelines talk about monotherapy or combination therapy. In terms of monotherapy, you can find that quetiapine seems to figure in almost all the lists. And then you have olanzapine fluoxetine combination that is there. And then you have lithium, you have lamotrigine, you have lorazepam. And cariprazine is something that has been cited in BAP guidelines, but not in the other guidelines because this is the most recent of all the guidelines that are available. So cariprazine in doses of about 1.5 to 3 milligrams per day has been recommended as a first-line treatment. The second choice drugs are again quite comparable. So you have lithium as a second-line drug in BAP guidelines, then you have valproate here, you have valproate and CANMAT guidelines. And most of these guidelines again talk about the role of antidepressants either in combination with a mood stabilizer or an antipsychotic. You can find the olanzapine fluoxetine combination is also available in most of these guidelines. In terms of third-line treatments, so you find most of the guidelines would recommend a combination of a mood stabilizer plus an antipsychotic, or in terms of monotherapy, you have adjunctive aripiprazole, acidapine, carbamazepine, and use of antidepressants is not actually recommended in the British Association of Psychiatric guidelines. So if you look at the treatment options that are available, just to summarize again, you have quetiapine, you have lorazepam, you have lithium, lamotrigine, and you have cariprazine, and of course the combination of olanzapine and fluoxetine as first-line agents that are available. So when you have these treatments available, this is probably the algorithm that you would follow. So the initial assessment would be, like I said, you assess what are the targets of treatment, where you would manage this patient, and what kind of risks are involved, and whether there's suicidal risk. If there is suicidal risk, then you would have to make an assessment of suicidal risk and decide on further management plan that includes whether ECT should be used as a first-line treatment. Then the next step is to initiate and optimize treatments with quetiapine, lorazepam, lithium, lamotrigine. So these are usually the recommended as the first-line treatments. Step two is, once you've given a trial for about 6 to 8 weeks and you find that the patient is not improving as much as you would like to, or if there's no 50% reduction in the rating scales, then you could switch on to alternate treatments like quetiapine, lorazepam, lithium, lamotrigine. Again, if you've started one, you switch with another one. The next step is to add treatments like valproate or SSRIs or bupropion as adjunctive treatments. And step 4 is to add on with various other treatments that are available. Right. So in terms of choosing the antipsychotic or the first-line treatment, I think it would finally come down to what are your targets of treatment. So if you have a combination of severe depression, you have suicidal risk, you have difficulty in sleep, if there are melancholic symptoms, then you know that you have 3 or 4 different combinations. So you have quetiapine, you have lorazepam, you have lithium, you have cariprazine. So the next thing that we need to see is what are the social demographic characteristics, what is the gender of the patient, what are the side effects that are likely to occur. So the choice of drug finally comes down to the target symptoms. So what are the drugs that are available for the treatment of target symptoms, and what are the side effects that are not desirable in your given patient. So it's a combination of the desired effect as well as the non-desirable side effects. So the drug that provides the best is probably what you would choose first, followed by switching over to one of the other drugs in case of inadequate response. So that is how I think most of us initiate treatment. So you use what drug has the most evidence in terms of efficacy, as well as that which has the least side effects in the patient whom you're treating. So let's say you're treating an elderly patient. So we know that lurasidone, quetiapine, cariprazine, and lithium can all cause the same degree of efficacy. So if I were to start treatment for a young girl, I would probably not use lithium as my first choice, simply because it can cause some side effects which may be intolerable to the young girl, and she may not want to take it. Whereas lithium would be a first choice in a young male of the same age. If I'm seeing an elderly gentleman, probably though quetiapine is one of the best drugs, I may be a little hesitant to start it. I would rather start off with lurasidone or lithium. So you take the the evidence that is available and tailor it to the requirement of an individual patient. We'll probably discuss a little bit more. So just to continue with this, so there has been a systematic review and network meta-analysis that has given us the evidence that is available for the treatment of bipolar depression. And most of these studies do show that olanzapine, quetiapine, cariprazine, and lamotrigine appear to be effective. Aripiprazole showed higher discontinuation rates versus placebo. And quetiapine was better than placebo at reducing treatment effective emergent effective switches. So when you do a network meta-analysis or a meta-analysis, what most of them look at are two possible outcomes. One is how effective the drug is, and two, what are the risks of dropouts from treatment. So it's a combination of both that most of these analysis take. And when you take that, you still find that the drugs that have been recommended as first-line drugs in the guidelines actually turn out to be the drugs that seem to work best for bipolar depression, even in the meta-analysis. So clinical factors that can dictate treatment choices. One is what is the rapidity of response that you want. So in that order, you would have ECT, quetiapine, lurasidone, cariprazine, and olanzapine fluoxetine combination. A lot of times we go with the drug that we have used previously and to which the patient has responded well. So especially if someone has had a prior episode of depression, then we should take into account that treatment. If there are features of anxiety that are there along with the depressive symptoms, then these drugs, quetiapine, olanzapine, fluoxetine, lurasidone, seem to have slightly better effect than the other drugs. In terms of mixed features, of course, you have OFC and acinapine and lurasidone. Avoid antidepressants, especially in patients with mixed features, as the risk of switching would be that much higher. If there are melancholic features, atypical features, psychotic symptoms, then drugs like quetiapine, lurasidone probably have a little bit more efficacy than a drug like lithium. So what are the advances? These are some queries that I think we should try and answer. What are the novel treatments that are available, and what role do they play in the treatment of bipolar depression? Do antidepressants have a role in treating bipolar depression? If yes, then how long do you continue antidepressants? And then, of course, the questions about brain stimulation for bipolar disorder, which I think our next speaker, Dr. Sai Krishna, would be covering. So I'm not going to intrude into his area. So what are the novel treatments? So you have ketamine, which has been used off late, particularly in patients who seem to have suicidal risk. There's riluzole, there's pramipexole, brexpiprazole, and of course, we have a new drug that is coming up, which is being tested, that's trimetazidine. So conventional agents are those that target dopaminergic and serotonergic systems, whereas the novel agents that I've highlighted here target NMDA receptors, norepinephrine and serotonin transporters. They're involved in glutamine modulation too. And some of them tend to have anti-inflammatory properties, which have been utilized in the treatment of bipolar depression, with the understanding that inflammation could be contributing to the pathophysiology of bipolar depression. So I think I'll just touch upon this a little briefly. I'm not going to go into the evidence. Ketamine, you have the NMDA receptor antagonist, which of course we all know is a dissociative anesthetic agent. It is believed to exert its antidepressant effects via the NMDA receptor antagonism and possibly inhibitory effects on norepinephrine and serotonin transporter gene. Pramipexole is something that is a D2, D3 receptor antagonist, which seems to have an antidepressant activity, particularly in patients with bipolar depression. And I think two small RCTs have actually evaluated it and found that significant improvement from baseline HAM-D score was noted, whereas in the other one it was not as significant. We also have brexpiprazole, which is a serotonin and dopamine receptor modulator. It's also has antagonism at the 5-HT2A and an adrenergic alpha-1A receptors, and it's a partial agonist at serotonin 5-HT1A and dopamine D2 receptors. So you find that there are different receptors and areas where these drugs act to bring about the antidepressant effect. In addition, the active form of thyroid hormone have been used as augmentation strategies in the treatment of patients with bipolar depression. So you find a lot of such drugs, including N-acetyl, cysteine. So you have what are known as nutraceuticals, which have been tried in the treatment of bipolar depression. So there is this network meta-analysis that kind of highlights all the various treatments that have been used in the treatment of acute bipolar depression. Trimetazidine, this is something that we have recently got approval for investigating as an acute treatment molecule for bipolar depression. This is an angiotensin converting enzyme inhibitor, which has activity on the mitochondrial energy generation. And 3 sites have been approved for testing this molecule, and NIMHANS and CIP Ranchi are partner institutions in this particular trial. So we hope that this will take off. But trimetazidine is something that, again, the reason is that we have earlier discussed that the number of treatment options that are available for bipolar depression are very limited. And if the patient doesn't respond, you exhaust your options very fast. So there is a need for looking at newer drugs and newer targets of action, which would give us more molecules available in our armamentarium to treat bipolar depression. So next question, are antidepressants useful in bipolar depression? Guidelines are not very conclusive here, but I would like to refer to this particular study that was done by the Indian Psychiatric Society, where 500 psychiatrists from IPS were randomly selected and were asked this particular question. 95% of them said that they prescribed an antidepressant plus mood stabilizer for bipolar depression. So irrespective of what guidelines say, we are prescribing antidepressants quite generously for bipolar depression. And SSRIs are the drugs that have been used by 88% of the psychiatrists, but not bupropion, which is actually recommended by guidelines. And ECT is prescribed very often as a first choice drug because invariably most of our patients come to us with suicidal risk. So if I can take you back to the first slide that I spoke about, the treatment gap for patients is about 70% for bipolar disorders, which means only 30% of them are accessing treatment, which means that the ones who are very severely ill are the ones who are coming to us for treatment. So it's understandable that most of them are getting ECT as a first choice treatment because they are suicidal. So whether do we use antidepressants or not, I think the answer would be yes. That is what I would say. Probably not as a first choice drug, but if you think the patient is going to benefit from antidepressant, then make sure that the mood stabilizer is at an adequate dose. I think that's the key. So if you're going to give an antidepressant along with lithium, make ssure that the lithium is at 0.8 milliequivalents per liter. If you're giving it along with valproate, make sure you're prescribing it at 20 to 40 milligrams per kg body weight. If you're prescribing it along with quetiapine, make sure the patient is on at least 300 to 600 milligrams of quetiapine. So it's important to ensure that the patient is on an adequate dose of mood stabilizer, which has attained steady state concentrations before you prescribe the antidepressant. Otherwise, with inadequate dose of mood stabilizer, the risk of switching may be high. And then we would unnecessarily blame the antidepressant, while actually it's an iatrogenic switch. So I think that is what I would say in terms of, yes, you can use the antidepressant. Try not to use the tricyclic antidepressants, even though they may be very effective because the risk of switching is that much higher. Where you can, please use bupropion. So the next question would be, I've used antidepressant, my patient has gotten better. When do I stop the antidepressant? All right. Now, conventional teaching would tell us that you stop at about 6 to 8 weeks after the patient has recovered from the depressive episode. But we also know that the average duration of a depressive episode is between 6 months to 9 months. So does it make sense for us to stop the medication on which the patient actually got better? If yes, what is the rationale? So that's a question for which guidelines don't give us any answer. It is left to clinical discretion. So we had the opportunity to actually investigate this in one multi-center study that was done at NIMHANS. And I think KMC Manipal was also one of the sites that was involved in this particular study, and Asha Hospital in Hyderabad. But the lead investigator was Dr. Lakshmi Atam from UBC, Canada. So here we were actually able to recruit about 177 patients from our site, and the entire world, about 222 patients were recruited for this particular study. So the study design was very simple. The initial first 8 weeks is a local label phase, where the patient would get either escitalopram or bupropion under the cover of a mood stabilizer. And then they were randomized after the acute phase into the double-blind phase. So people with escitalopram were randomized to receive either escitalopram or escitalopram placebo. And those on bupropion were getting bupropion or the placebo. Continued for 52 weeks. So now this is the study that this is what we found, that the time to any mood episode was longer in the group which received antidepressants for a longer period of time, relative to the group where antidepressants were stopped at 8 weeks. And the time to a depressive episode was significantly longer in the 52 weeks group. Of course, we did find that the risk of switch was a little higher with escitalopram than with bupropion. But adjunctively, when used with a mood stabilizing drug for at least a period of 1 year, the risk of another depressive episode seemed to be much lesser with 52-week antidepressant than with 8 weeks antidepressant. So this is something that I think finally we would probably have a little bit more we'd be a little more comfortable in prescribing the antidepressant and keeping the patient on the antidepressant for a little longer period of time, because we know that it is not causing as much switch as we expected, while at the same time it's preventing a further new mood episode. I hope I have not exceeded time. I'll finish in a couple of minutes. Thank you. So again, sticking to what the work we've done in the recent past, I'm not going to talk much about this, but we did find that ECT worked as well for bipolar depression as it did for unipolar depression. And the switch rates, in fact, we don't seem to have much information, but the other question is when do you start ECT and when do you stop ECT? A lot of times we tend to undertreat with ECT, and especially if there is catatonia, we tend to stop ECT a little faster, but then the worsening of symptoms can be as rapid if ECT is stopped very rapidly. So that's something you should keep in mind. And some work in TMS that we had, we had the good fortune of doing. So this was again meta-analysis which looked at the clinical efficacy and safety of RTMS in acute bipolar depression, and we found that high frequency of the TMS, active TMS was far more effective than sham TMS in treating acute bipolar depression. Again, let's remember that most of these were treatment-resistant bipolar depression. And in terms of the different modalities of treatment, high-frequency stimulation was actually more efficacious than sham, whereas the low-frequency stimulation and theta burst did not seem to show much difference as compared to sham treatments. Now, what are the things that are available for maintenance treatment? Now, we all know that in maintenance treatment, we try and continue on a medication which we have started off in the acute phase. So when you're starting a medication, the life chart of the patient is also extremely important. So if you're starting someone on quetiapine or lithium and you plan to continue them as a mood stabilizing agent, then the important things that we need to keep in mind is what is the ability of that particular drug to prevent future episodes of depression and future episodes of mania. Okay, so right now somebody is in depression and you want to give them a drug that is going to prevent either. And as you can see from the evidence here, lithium and quetiapine seem to have the most evidence, followed by a combination of quetiapine with a mood stabilizing drug. So these are the three drugs. So in case you're going to start somebody on prophylactic treatment and you would like to continue them on
the meeting.
Start off in the acute phase, probably quetiapine or lithium would be one of the best drugs to use. Bipolar 2 depression, again, just referring to some work that we had done earlier. So this book contains a chapter on the treatment of bipolar 2 disorder. So one of the important things in bipolar 2 disorder is that it can be frequently misdiagnosed as many other disorders. So like Dr. Mishra mentioned a little earlier, if you're getting a patient with frequent episodes of depression, look for indicators of bipolarity. Systematically probe for hypomanic symptoms. He did mention the mood disorders questionnaire. And then you look at all the possible differential diagnoses: bipolar 1, borderline personality disorder, attention deficit hyperactivity disorder. And then you do a close monitoring of the patient to confirm the diagnosis. So what are the treatment options that CanMed guidelines recommend? So quetiapine is the drug for which most evidence is available for treating bipolar 2 depression, followed by lithium, lamotrigine, adjunct to bupropion, ECT, sertraline, venlafaxine. Now, as you can see, there are a lot of antidepressants that are being used here, and there have been studies which have used fluoxetine and other antidepressants even without a mood stabilizer. Of course, that's not something that I would advise. But of course, if you're using it, make sure that you're using an adequate dose of a mood stabilizer. A lot of times when patients may have a hypomanic switch while you're treating them for bipolar 2 depression, a small dose of an antipsychotic added to it can very often bring down the hypomania. Because as we all know, hypomanic episodes don't tend to last for more than 2 to 4 days. And it's important for us to treat it appropriately to prevent it from going into full-blown mania. To summarize, bipolar depression is a challenge for all physicians. Suicide is quite high in bipolar depression, which makes it even more of a challenge. The number of treatment options are limited, which means that the treatment choices have to be made rationally and tailored to the needs of the individual patient. Lithium and second generation antipsychotics like quetiapine, cariprazine, and lurazidone are the mainstay of acute and maintenance treatment. Novel treatments are being explored, including dextriprazole, trimetazidine, and ketamine. The role of antidepressants in bipolar disorder is unclear, but of course, if you're using an antidepressant, make sure you're using it under the cover of an adequate dose of a mood stabilizing drug. Bipolar 2 depression poses a bigger challenge as of now because the treatment options are far more limited. And like I said earlier, guidelines must be used to tailor the treatments to individual patients. And thank you so much for your attention.
Yeah, Sudhir sir, you are not audible.
Am I audible now?
Yeah, yes.
Yes, sir.
The role of substance abuse. Could you just elaborate a little bit on that? Because that's a very important variable which we normally see in a clinical practice.
Yes, sir. So if you look at substance abuse and bipolar disorder, we know that that's probably one of the most common comorbidities, and we know that it's fairly common. But again, when you look at clinical trials that are there for bipolar disorder, you find that most of them actually are not including substance dependence as one of the. So it's actually quite far removed from the naturalistic course of bipolar disorder. But of the drugs for which some amount of evidence is available, you find that valproate seems to be a drug that has quite good acute as well as prophylactic efficacy when used in patients with substance use disorder. There is also a lot of evidence for carbamazepine for its role in comorbid, so what you would call dual diagnosis, comorbid substance use as well as bipolar disorder. If you look at network meta-analysis for the treatment of acute mania, you would find that carbamazepine is a drug that seems to be the most effective. Of course, probably because of the less favorable side effect profile, it's not a drug that is used quite well. But that's another drug that you could use quite effectively in patients who have comorbid substance dependence.
Another option could be oxcarbazepine to take care of the side effects.
Sorry, sir?
Oxcarbazepine. Oxcarbazepine.
Oxcarbazepine, yes, of
That
course,
could
that
be a
is
better
available. But
option.
then it's the number of trials in bipolar disorder are actually much less. But of course, it's the more active metabolite of carbamazepine. It does take care of side effects. A point.
Thank you.
Yeah, so those are the two drugs that I would recommend. So, but in terms of acute management, I think irrespective of whether someone has substance dependence or not, most of the drugs that work for the acute management seem to work well irrespective of whether there's comorbidity or not. Further, I think if you're using a drug like olanzapine and someone has a nicotine dependence, then probably we would use a little higher dose than what we would be using in patients without.
Lower level, that level. Thank you. Thank you very much. Sanjay, anything to add?
Nothing less than yes, substance abuse is pretty common in this group. I just asked one thing: why bupropion has not been used so
Correct.
frequently, though it is there in many recommendations.
So, like I said, it's the guidelines do recommend that bupropion seems to have a good efficacy, and the switch rates are quite low. But it has not actually been used as much. And if you look at even the prescribing practices of our IPS psychiatrists that was published some time ago, very few people actually made the choice of bupropion. One of the things that I do remember is that unless you're preparing, prescribing the Excel preparation, the frequency with which the drug has to be taken can be a bit of a put off. The side effects of loss of appetite that people with bupropion experience is another thing that So the intolerable side effects at times are reasons why people don't want to continue on bupropion, or people don't want to start patients on bupropion. But otherwise, if the options are limited, and if you have kind of exhausted most of the other options that I mentioned, bupropion would be a wonderful drug to use, as borne out even in our trial that we conducted at NIMHANS some time back. In fact, patients who took it for about 52 weeks, they had better prophylactic value with bupropion than what they had with acceptable. So both in acute and prophylactic phase, bupropion does seem to have some degree of efficacy in treating and preventing depressive episodes. We should use it more.
Yes, that is what
Thank-
I also feel.
I use a lot of bupropion. Thank you. I think we could go on to the next session. You can answer the questions in the Q&A session. Thank you very much, Dr. Murali, for a fantastic presentation. Thank you very much.
Thank you, sir.
Thank you, Dr.
I'll wait for the
Murali, and
questions.
thank you for co-chairing with me, sir.
Thank you, Sanjay. Always with you.
It was a wonderful and insightful talk by Murali sir. And we all have issues in managing bipolar depression. It starts from dissecting out unipolar depression with bipolar depression. That itself is a mammoth task in our routine day-to-day practice. And then management is another task that we face in our day-to-day practice. So with this, we would move to our third speaker. Our third speaker is Dr. Sai Krishna Tikka, sir, currently Associate Professor in charge, Department of Psychiatry of AIIMS Bibinagar. And sir would be speaking on the brain imaging techniques, the findings of it, and the neuromodulation, which can be applied for bipolar depression and its translation to bedside clinical practice. For this, we have Chairperson, Professor Dr. Basudev Das, sir, and Dr. V.A. Sriraj, sir, from NIMHANS. Professor Dr. Basudev Das, sir, is currently the Director of CIP Ranchi. Sir has more than 15 years of teaching experience and has won many national awards in IPS zonal and national conferences. Has to his credit more than 60 publications in both national and international journals. And currently he is the Director Professor of Psychiatry. And he also holds the post in NIMHANS for as Associate Professor of Psychiatry before the current post. His current area of interest is mood disorders, OCD, child adolescent psychiatry, psychopharmacology, psychopathology, headache, and seizure disorder. Our next chairperson for this talk is Dr. V.A. Sriraj, sir. So, sir is currently the Assistant Professor, Clinical Research Center for Neuromodulation in Psychiatry, Department of Psychiatry, NIMHANS, Bengaluru. Sir did his DPM from CIP Ranchi and DNB from Institute of Mental Health and Hospital, Agra. He also did his PDF, postdoctoral fellowship in clinical neuroscience and therapeutics in schizophrenia, and from NIMHANS, Bangalore also. Sir has to his credit more than 74 papers in national and international journals and 2 book chapters. He has to his credit, he has a research interest on neuromodulation, neurobiology of psychiatric disorders, psychotropics, psychotropic response, resistance, and adverse effects. And has to his credit the Best Paper Award in SIPCON 2013 from Central Zone of IPS. He also got the Young Researcher Award for the second best paper in ICOMS, International Conference of Schizophrenia, in 2014 by SCARF India. He also won the 2017 ICMR Travel Grant Award and also got the 2019 Young Investigator Award for World Federation for Society of Bipolar Disorders, and also the ASHA Award in 2021. Over to you, chairpersons, to moderate and chair the session by Dr. Sai Krishna Tikka, sir.
Yeah, thank you, Dr. Santanu. First of all, I want to thank all the organizers, and I would also thank my co-chair, Basudev Das, sir. So I'm kind of feeling privileged to be in this platform now, and Jharkhand state being the first state where I entered into the psychiatry as well. And yeah, it's also kind of a pride movement to be the chair for Dr. Sai Krishna Tikka, who was my senior during my DPM days, and then he is one inspirational figure and a leading psychiatrist and academician in psychiatry. And he has completed his MBBS from Mysore Medical College, then DPM and MD from CIP Ranchi, and he had also had DBT INCRE fellowship on his armatorium. Currently, he is working as associate professor and in charge head of AIIMS Bibinagar, and he has been extensively working on many areas, including brain stimulation, neurobiology, and psychophysiology. He had a lot of publications, like around more than 85 journal articles, more than 22 books, and with a very high index of 16. He also has a lot of IPS awards on his shield, and he's also been an associate editor and early career editorial board member of prestigious journals of India and international domains. So with this, I would like to seek permission from Das sir to go ahead and initiate this session. I'm not sure if Professor Das is around.
I think sir is not there.
Okay, maybe then I will take the privilege to initiate the session and request Dr. Sai to initiate the session.
Thank you so much, Sriraj. Indeed, pleasure, and I hope I'm audible.
Yeah.
Indeed, a great pleasure to be here and an honor to be presenting here. I would like to first thank the organizing committee, Dr. Shantanu, Dr. Nasimha, for inviting me, to deliberate on this important topic of bipolar depression. And first of all, congratulations also to you, to hosting the first midterm CME of the Jharkhand State Branch of the IPS, to which I am very closely associated in the past too. Again, it's a pleasure to be, talking where Dr. Basudeva sir is the chairperson along with Sriraj. My sincere regards to all my seniors, Dr. Diram sir. I could see Dr. Jaiti ma'am too, Munda sir, Avinash sir, and I completely share the feelings that Dr. B.R. Mishra told initially, where he told it is as if I'm presenting a seminar in the Berkeley Hill Hall, and going through his session, I always felt that he is my senior resident mostly, and I'm listening to him. So it's a very close association and a nostalgia to me here. And my sincere regards to also Dr. Saurabh Varshney sir, who I had the opportunity of meeting him when I was at AIIMS Rishikesh for in a small stint there. Thank you very much, sir. This topic that I'll be talking about, that is imaging brain stimulation in bipolar depression. How does it translate into clinical practice? In the title, when the term comes, translating to clinical practice, that actually tells that it is not in clinical practice right now, and there are high chances that it will come up later on, and what are the prospects of it. Dr. Muralidharan sir, who spoke just before me, he himself is an expert in this, and was telling about various options of treatment which are available, in for bipolar depression. Currently, brain stimulation, except for ECT, other modes of brain stimulation do not reflect in these. So, I would rather talk about those things from a perspective of how neuroimaging can help brain stimulation. So the basic heads in which I'll be covering this topic is, I'll start with various neuroimaging findings in depression and bipolar depression. Then I'll go into a few details about the current evidence base for non-invasive brain stimulation in bipolar depression. Then how neuroimaging can help non-invasive brain stimulation outcomes in bipolar depression. And finally, I'll talk a bit about how this translation from neuroimaging to brain stimulation to clinical practice can happen. So like both the speakers before me told, bipolar depression is a challenge, both in terms of diagnosis as well as treatment. So it's an enigma to us. It's that Rahul Dravid, who we know that he's technically very sound, but, not getting not much of attention and, the kind of popularity as other disorders like schizophrenia. So I would just like to reiterate some of those points which were there in the featured in my previous talks. Depression is a predominant psychopathology. Also in those who are treated. So even during remission phases, the depressive symptomatology is quite common. There are more relapses, unstable response, leading to higher morbidity and higher hospitalizations. The depressive phase and time in depression and the hospitalizations are again, predictors of suicides, which are, quite common in cases of bipolar depression. Higher mortality is not just from suicide, but also from medical comorbidities that coexist with bipolar depression and their treatment too. Overall, the evidence is less when compared to, unipolar depression. And whatever the emerging evidence is, it's got modest response to whatever new molecules that are there. So this means that, there is a prospect for investigations, prospect for research into other modalities that can be helpful in treating this challenging disorder. When we talk of Enigma is a consortium. It's a worldwide consortium which is called as enhancement in neuroimaging and genetics using meta-analysis is a full form of Enigma. There are several countries now. This is around 2 years back, but India is also on the list of this, where NIMHANS is on this map with some neuroimaging research and genetic research from in the field of child psychiatry. So this is a paper which is about research that has happened in the last 7 years, and an overall review of different neuroimaging findings. So neuroimaging for us, for general clinicians, these terms are very not so common. I would like to simplify that in my talk. So the imaging starts from CT scans, the MRIs, not just structural, also functional MRIs. Then task and functional MRIs are both, again, resting state functional MRIs and also task-based functional MRI findings. Then other kinds of analysis that happens in MRIs. Also other forms of neuroimaging like SPECT and diffusion tensor imaging, etc., etc. So what they have found is that in a gist, the neuroimaging findings which are cortical in nature in major depression. I would start from major depression, go on slowly on to the bipolar depression. So there is lower thickness, the cortical thickness is lower in 13 out of 68 cortical areas that have been seen. So most prominently, these are the bilateral medial orbitofrontal cortex and the bilateral rostral anterior cingulate cortex, the cingulate which is just below the callosum. So these are the two areas that they found out that there is significant effect size in depression. Subcortical regions, there's fair bit of evidence that tells that the hippocampal volume is the only subcortical area where the effect size is quite significant. And the reduced hippocampal volume is not this is an intriguing thing. It is not present in the first episode of depression, but it happens with the volume deficits increase as the disease progress. So more the number of episodes, more the amount of times that is spent in depression leads to reduction in the hippocampal volume. But another intriguing thing is this hippocampal volume is reduced in adolescent onset cases of depression, which is more adolescent onset depression is whenever that is happening, we see that whether there is any bipolarity there or not. And another important thing, very fortunate thing, is that it normalizes in remission. So this is more of a marker of state where if there is depression, the volume is less, and when the depression improves, the volume normalizes. So this is about the hippocampus. There are white matter microstructure abnormalities, the myelin integrity, there is higher myelination, and this is restricted to two areas: the corpus callosum, the G1 body specifically, and then the corona radiata. So these are the certain regions in the brain where we can say that the abnormalities are more in cases of major depression. Now, how do they do in comparison in bipolar depression in comparison to the unipolar depression or major depression? What you could see in this figure is that the deficits in the major depressive disorder are quite restrictive. They're in only few regions of the brain, whereas in bipolar depression there is widespread deficits in terms of cortical thickness, cortical as well as subcortical regions, and more so in schizophrenia. So there is a spectrum called the affective psychosis spectrum, which begins from unipolar, and the highest, wider, most the structural deficits or neuroimaging deficits are there in the cases of schizophrenia, and bipolar depression, bipolar disorder lies somewhere in between them. So, and also this is evident from the effect sizes of subcortical regions. You see hippocampus in MDD is lower. Highest deficits are in schizophrenia. The green line is the bipolar depression, where you see that it is there, but not as high as schizophrenia, but more than major depression or unipolar depression. There is more of evidence from different other sources, not just structural MRI, also from resting state functional MRI, where they say that the activity patterns, the neural activation patterns in certain areas is higher than unipolar depression and lower than unipolar depression in certain other areas. Specifically, I would like to just summarize these things. So, in terms of areas that are been commonly found. So prefrontal cortex, conventionally, this is the area where more research is. So it is found that in cases of bipolar depression, the prefrontal cortex is thinner than in cases of unipolar depression. So there is gray matter and white matter volume deficits in prefrontal cortex. The central executive and the salience networks. So central executive network is a frontoparietal network, again cortical network. Salience is more of subcortical. It is the cingulate to insular network, which is more important for salience, understanding of salience and all that. So there it's been seen that when people with bipolar depression are given the stimulus of emotional processing, whenever they see sad faces, whenever they see happy faces, there is higher activation, functional connectivity in this area than compared to unipolar. A bit was also highlighted in the talk by Dr. B.R. Mishra, sir. What's important is this activation. It has been seen that it is much more when they see happy faces than when they see sad faces. That's an intriguing thing. The other areas where the deficits are is the right anterior cingulate cortex, where there are volume deficits. Then this is choline creatine ratio on SPECT imaging, where it is seen that in both bilateral, anterior cingulate cortices, this is predominantly lesser than compared to unipolar depression. Then orbitofrontal cortex, that's an important cortex, especially it is part of the salience network too, where it is seen that the local connectivity, in this particular area is quite higher in bipolar depression cases than compared to unipolar depression cases. Then both right and left insula are involved, whereas the activity is lower in the left insula, the activity in the right insula, the task related activity is higher in the left insula and it is lower in the right insula. So there is a differentiation, there is a dissociation of task related activity insula. So insula is an important target for us to understand when we are differentiating unipolar depression and bipolar depression. So, and more importantly, when you see what does this research tell, what do they do? They simply compare the cases of bipolar depression and unipolar depression. The main diagnostic entity that the challenge that we have is, already highlighted by previous speakers, that when the first episode is depression and it is not preceded by mania, it's a big challenge to us. So I just wanted to look up are there any studies which tell that, in cases that have been transformed to bipolar later on, are there any neuroimaging findings that tell us? So there is one, I just found out a few, I just wanted to highlight one. And these say that the meso means the ventral tegmental area to the ventral striatum. Ventral striatum is nucleus accumbens there. In that area, the functional connectivity is lower. So this is specifically seen in cases of unipolar depression, initially thought to be unipolar depression, but then which later transformed on to become bipolar depression by having hypomanic and manic episodes in the past. So this is a retrospective study that they did. When initially what they see is this difference, that on fMRI there is reduced functional connectivity in the regions between the brainstem and the ventral striatum. So, but then we talk about many various issues and all that. But by convention, it is a hypofrontality. When I was doing my post-graduation as a student, we read about a lot of hypofrontality, which is still there. It all started with hypofrontality by certain neuroimaging technique like SPECT in later 80s and early 90s, and based on which actually it kind of endorsed the evidence base that ECT had in cases of treating depression. So hypofrontality, ECT reduces the hypofrontality or improves the hypofrontality, and that is how the treatment response, the very good treatment response that we see in cases of depression has been understood as. So from currently, what is the evidence base for ECT? This is a recent meta-analysis which compares unipolar depression and bipolar depression. What they see is that although the remission rates are not different, the p is less than 0.05. So, but the response rates are significantly higher in cases of bipolar depression compared to unipolar depression. So the effect sizes is modest up to 0.7, and this research also tells that bipolar depression cases actually required fewer number of ECT sessions for this response to happen, and this is an important finding for us. So, and again, like I've told you, how we can relate this to neuroimaging findings is ECT improves hypofrontality and also other related hypotheses that are there. Now, coming to the evidence for repetitive transcranial magnetic stimulation, which is the other most commonly used form of non-invasive brain stimulation in psychiatry and for depression specifically. So, there are few systematic reviews and meta-analysis that have only seen reviews which are there in bipolar depression. Yeah, and but this is one systematic review and a meta-analysis which included trials across various disorders. So, and then what this studies tells that is high frequency stimulation, which is excitatory stimulation to the left DLPFC, is quite effective in cases of unipolar depression. But the same is not very true for cases of bipolar depression. Yeah. So one second. Yeah. So not much of evidence. The evidence is still coming up whether to use RTMS in cases of them or not. Yeah. Okay. Am I audible?
Yes, sir.
Hello.
Yes.
Yeah. Okay. So the evidence is still coming up. So there are people who are talking of different parameters. We in fact attempted the use of intensive stimulation, which is giving more number of sessions in a day, and other patterned TMS like theta burst, again found not so convincing results. In terms of suicidality, RTMS has been used, and again for cases of bipolar depression, this is a systematic review that we conducted. So again, we found that the response is not high in cases of bipolar depression for the use of RTMS in suicide. Also, there's a danger that RTMS, when delivered to certain target areas, in cases of bipolar depression, can enhance the chances of affective switch, which generally happens with use of antidepressants. The research on this is not very thorough, but then yes, there are chances of this too. And for the use of TDCS, not much of evidence is there. The evidence is still emerging, but still insufficient to say that to be putting into clinical practice. So if you see this evidence, in total, generally, what we see is that if the bipolar depression is severe and responding, that tells us probably that hypofrontality is in action. So we are somewhere hypofrontality is in the forefront. But in cases where hello. Am I audible?
Yes, sir.
I think,
Yes, audible.
but your sharing is off screen share mode. So
Yeah.
yeah.
Is this
now-
fine?
Yeah.
Yeah. Okay. So there is hypofrontality probably in those which is the cases where severe, where ECT is indicated and they are responding. In those which are moderately severe but not responding and enduring, we have to question hypofrontality because there is evidence that other areas in the brain are also important to look at. So can neuroimaging help these non-invasive brain stimulation outcomes? There are so many neuroimaging findings that we found out. Whether this can help us improve the parameters that we select for non-invasive brain stimulation, the kind of non-invasive brain stimulation we try, will that affect? So in the gist, neuroimaging suggests that there should be stimulation of alternate cortical areas like the orbitofrontal cortex. There is a requirement of a widespread stimulation, maybe not specifically to only certain areas, like specifically prefrontal cortex, and also stimulation of deeper structures, and not only cortical structures but deeper structures like anterior cingulate cortex, insula, striatum. So in line with this, there is some evidence coming up for the use of RTMS which is targeting the orbitofrontal cortex in major depression and obsessive compulsive disorder. I couldn't find any study which actually has seen bipolar depression. So this is one chance where this can be used. So use of RTMS for stimulating orbitofrontal cortex in cases of bipolar depression. When I talk of deep, wider stimulation, there is this new thing called as H coil or deep TMS. So there are 3 deep TMS that have been FDA approved. One is the H1 coil for major depression, which actually is more wider than what the traditional TMS coil. Much more wider is the H7 coil, which is used for OCD, and also FDA has now approved the deep TMS for smoking cessation. So then that is called as H4 coil. They have got wider stimulation than the conventional TMS coils that we use. And when I talk about deep TMS, then I can talk about deeper structures that I was telling about, that is cingulate cortex, insula, etc., etc. Like first, the deep TMS was approved for depression, then for OCD, where the OCD actually was stimulating areas that are medial prefrontal and anterior cingulate cortices. And for smoking cessation, the areas that are being targeted are insula. So with the use of deep TMS, we can actually stimulate areas that are implicated in bipolar depression more than unipolar depression, like anterior cingulate cortex and insula. So this is one way how neuroimaging findings can help us, in the use of non-invasive brain stimulation. Then when I talk about insula, hippocampus, and the alternate technique which is there, that is called as transcranial direct current stimulation. There's something called as GVS, which is galvanic vestibular stimulation. Galvanic vestibular stimulation, where the TDCS is applied on the mastoids and it kind of stimulates the vestibular system. The hypothesis is that the stimulation reaches the insular cortex and also the hypothalamus and hippocampus. So the areas which are implicated can be stimulated by using these alternate techniques of brain stimulation. And obviously the evidence is not much. In fact, nothing in cases of bipolar depression. But then it gives us an opportunity to try out these things, hypothetically. Then when I told ventral striatum and much more deeper structures, then deep brain stimulation is there. And there is quite a bit of evidence in deep brain stimulation for treatment-resistant depression. The areas that have been targeted so far are around 6 to 7. Most commonly the subcallosal cingulate gyrus and the ventral striatum. Those are the ones which we are also wanting to be stimulating in cases of bipolar depression. So deep brain stimulation also gives an opportunity to be used in these cases. But how clinically, how effective they will be, more and more research is required for that. So then now when I talk about all these things, whether this is translatable, like I told it in the beginning, the translation is not much currently, but then there are definitely, this is the road ahead. So there is something called personalization in non-invasive brain stimulation. So we do that, more than what we do for pharmacological agents. The parameter selection, is based on the motor threshold. We see individual motor threshold and determine the intensity. That's quite personalized for each case. And then, the parameter selection can be based on the activation patterns that I have shown it in functional connectivity. If the functional connectivity in an area is higher, we choose a inhibitory pair protocol. If the functional connectivity or the activity patterns are a little lower, we can choose accelerated protocols. Then also the target localization, there is quite personalization. Now with the FDA also approving certain neuronavigation techniques, I have worked in CIP has a very good neuronavigation center. In fact, has an RTMS system which can be given inside the MRI the suite. So initially we did some research where we used the structural MRI as neuronavigation to select the target locations. There is a study from All India Institute of Medical Sciences, New Delhi, where they have used SPECT not for guiding the target locations in TMS. And off late there is this new paper which is using functional MRI, the connectivity patterns itself, the connectivity between the prefrontal cortex and the subcallosal cingulate cortex. They saw the functional connectivity. Wherever there is less connectivity in that particular area, they only stimulated that area. So this is the kind of direct translation and the personalization that that neuroimaging can help in the use of non-invasive brain stimulation. Now coming to how this brain stimulation can get into clinical practice. Dr. Muralidhar actually also told us about the new the Royal College of Australia and New Zealand guidelines. There's a bit of controversy as well when the Royal College suggested the use of RTMS in the use of for the treatment of mood disorders, and for bipolar disorders they still don't recommend that, but for major depression they do. There's a controversy that whether they should have included that or not. But there are other guidelines. The American Psychiatric Association, the National Network for Depressive Disorders, that they suggest use of RTMS in depression, and then say there is modest evidence for that. The German guidelines also are there for the use of repetitive transcranial magnetic stimulation in depression. In fact, recently, only last week, we had this meeting of Indian Psychiatric Society where we are in process of forming the clinical practice guidelines for the use of RTMS in psychiatric disorders, and part of that group, I am part of that group. Again, we still say that the evidence for bipolar depression is low and the recommendation is also quite low. But then with the advent of so many other techniques and with the use of neuroimaging for that, I think road ahead is that somewhere down the line this will come into clinical practice, definitely. Thank you so much.
Yeah, thank you, Saibos. So, yeah, after this, we had a wonderful talk by Dr. Sai. I think we are in an interesting time period where we have been able to see a lot of advancements which are happening in neuroimaging, as well as which is getting
Sriraj, you are not
translated.
audible. So, I don't know whether I am able to listen. Yeah.
Am I now?
I think he's
Yes.
audible.
Yeah, probably there was some problem with me.
Yeah, no issue. So we are in this area where there are a lot of translations which are happening. I think the advancement in understanding the connectomics is something which is leading the field towards understanding better about how we can modulate those connectomics, and probably which can get translated into the clinical field. But it's also true that at the same time, probably our understanding is still at a lower level. So that's why, like bipolar disorder, our understanding or our concepts are also quite swinging. We started with ECT, where we were stimulating a broad area, a large area. Then we started looking at focused stimulation. We started looking at where we can be more precise. But I think that precision is not been something which was easily replicable. So again, we are going towards stimulating a little wider regions, and with also something which we are trying to stimulate even the deeper regions as well, right? So yeah, alongside, I also wanted to ask one question to Dr. Sai regarding the effects of illness. I think there are a lot of imaging uh, understandings which are coming up from the neuroimaging, where the episodes, how the episodes or the primarily the manic episodes, depressive episodes, and the presence of psychotic symptoms, how they can impact the structure as well as the functioning of the brain. So you want to respond?
Yes. Actually, that was again very surprising to me initially, that when we as students, were told that there are these deficits which are there in these disorders, we felt that those deficits are probably, developmental in origin, maybe, or they are the ones which actually led to these symptoms. But I also mentioned about this Enigma trial, which tells that the hippocampal volumes, are lower when someone is having an episode, and then they come back. Then the volumes actually normalize once they are in remission. Similar patterns are seen for manic episodes and schizophrenia episodes too. And there is some differentiation here, between whether the onset of illness is during adulthood and whether the onset of illness is during, early childhood. In those cases where the onset of illness is during childhood, it has been seen that those volume deficits are present even, before the illness, pre-morbidly too. So the way we look at these findings is now, the horizons are a little wider. When we look at childhood onset symptoms, we look at these volume deficits are mostly as developmental in origin. And when we look at these findings, in adult onset cases, we look at them as disease progression, or in that sense. So and again, when we target regions, when we say target locations for brain stimulation, so these are the ones which you should not be looking at, because they will automatically improve with treatment. So they may not be directly related to the severity or the illness process, but maybe an outcome of it. More so, the targets that we should be looking at are the ones which are getting modulated with respect to, certain symptoms, suicidality, something like that. Where on this particular field, the research is not much, which specifically looks at different symptom profiles and sees what are the patterns that are there. I guess I could answer that.
Thank you so much for the excellent insight. Probably, yeah, we have crossed some time, so I would again like to thank you for such an excellent presentation. And I think we have a Q&A session now, which will be handled by Dr. Santanu. So I will end this session formally and hand over the session to Dr. Santanu.
Thank you, Sridhar sir. Indeed, it was a nice talk, Sai sir. And we know that you have a special knack for neuromodulation, and it was nice to hear about the current evidences. And you are right to say that translating into practice is something that we need to look into in depth. We have evidences, but translating to practice is a question of the art. So with
Just
this,
a comment before you move on,
yes,
from what Siraj was telling, like our knowledge on these, the areas which are to be stimulated and the actual effects of RTMS is lesser, in those who are also doing. But then, the use of RTMS has grown up. Most of the consultants in the practice, they use RTMS much more than what we do in institutes. And also from a patient point of view, the preference for RTMS over not only ECT initially, but now the preference of RTMS is over psychopharmacology too. So they come saying that we don't want drugs, but then if you have RTMS, please let us know. So the demand is much more, and we need to understand more about what to be done, what to be used at what point. Thank you. I'm sorry to disturb you.
no issues, sir. Thank you for clarifying this thing. We three of our esteemed speakers have spoken in depth about the phenomenology, about the treatment options, how to translate into clinical practice, as well as the brain imaging techniques, the findings, and the neuromodulation issues, and its translation to bedside. So we can see there are multiple questions in the chat box, and as Dr. Narshima has mentioned in the chat box, we have an award for the best question. So I'd like to start with one by one question to the speakers, and I don't know how much of the questions will go to our speaker, but we'll start. Dr. Udayan Bhakat has questioned that, sir, in ICD-10 it states that in recurrent depressive disorder, the course may consist of hypomania-like episodes, especially after resolution of depressive symptoms. Keeping this in mind, how to approach to a patient to differentiate recurrent depression with bipolar disorder 2? So I think I should ask Dr. B.R. Mishra sir to answer this question by Dr. Udayan.
Okay. So thanks for this question. What I understood is in advent of a recurrent depressive episode, if we are getting features of hypomania, symptoms suggestive of hypomania, then how should we go about it? I think that is what is intended from the question. Okay. So again, as I told you, that the exact discretion, treating a patient coming from a state of depression to normalcy versus a patient transiting to hypomania, there is a lot of subjectivity, and as in many clinical scenario, we face this challenging issue. That whether the person has transited from the depressive polarity to the stage of normalcy, or else it is something different. Presence of hypomania in the history, if you are clearly able to get a history of hypomania, or there is a history of drug-induced, antidepressant-induced switch, then definitely, if you're very clear about it, then a possibility of bipolarity should be given more importance. Unless otherwise proved, bipolarity should be given more importance. But if we are considering, if we are not sure about it, then it is better to approach the patient with antidepressant treatment. And another issue is it may not be much relevant to this question. Suppose a patient presents to us in a state of depression, but there are hinters of bipolarity. But we are not very sure that this is bipolar depression. We have a confusion in our mind. Then what should be our approach? Should we start him on a mood stabilizer directly, or we should continue with antidepressant treatment? So what is usually followed is unless otherwise proved or we are very sure about it, treating with depressive episode in lines of depression is favorable. And but we have to be very careful regarding the issues of development of any switch or any kind of rapid mood fluctuations. If you get that, then you have to change your treatment approach. If there is a light of, if there is any, still there is any clinical doubts regarding the choice, then olanzapine fluoxetine combination, which is recommended by our guidelines, can be a very favorable non-controversial treatment option if the patient is having psychotic depression, but where we are not very sure about whether it is falling into the unipolar category or the bipolar category. That can be a take-home, like we can safely go about it. So this is what I hope I was able to answer the question which was intended.
Thank you, sir. Our next question is from Mr. Vijay Nalawala, sir. Sir is the founder of Bipolar India, and we are happy that sir is here in the platform. And it's an online community setup for sufferers by bipolar disorder, and it has played a major role in alleviating stigma and setting up the community build up for people suffering from depression, bipolar disorder, mood disorders to be precise. And I have the privilege of following sir in Twitter also. So sir has asked a question. Isn't bipolar type disorder type 1 sometimes wrongly diagnosed as type 2 and vice versa? Over to Dr. B.R. Mishra, sir. And also the second question by sir is that whether comorbid, like how much challenge it is there in a clinical practice when bipolar disorder and OCD are comorbid with each other?
Okay, like if we see the literature, what it states is the diagnosis of bipolar 2 is much more difficult as compared to bipolar 1. Bipolar 1 is somewhere where there is a syndromal diagnosis of mania and the dysfunction is very clearly evident. But the problem lies, the trick lies where you are in a state to diagnose a discrete episode of hypomania. There lies the question. So at times, there, as I have presented in my slides, that like there can be recall biases and there can be issues related to focusing more on the mood changes, which can be normally seen in individuals also. Mood changes can normally be seen under advent of any kind of psychosocial antecedents. But these like a good way that there is the bipolar 2 is definitely something which may be unnoticed, which may be underdiagnosed in view of lack of uh, lack of our own confidence in being able to elicit a clear history of hypomania. So it is always a trick. So obviously, and that is what the literature tells.
Thank you, sir. Any comment from Vijay, sir? If you can put your comments.
Yeah,
and any
thank
questions,
you so much for elaborating on that, doctor. And the second part of the question was how challenging it is when there is a comorbidity of OCD in bipolar disorder. We have several members in our community who have OCD, and there is a conflict in the treatment between OCD and bipolar disorder symptoms. Is that right? And how does that? Then how does that? How is it managed then, in psychiatry.
Thank you, sir. Our next question, we have a couple of questions from the organizing team as well, but we'll first of all take the questions of the participants. Dr. Kishore has spoken, has asked, this will be a question
I think the question from Mr. Vijay Nallawala was not answered.
Oh, sir, I missed.
So maybe I think I'll take that question, sir. Probably it's intended for me. So yeah, it is. First of all, let me place on record my appreciation for your efforts in ensuring that people with bipolar disorder are able to connect with each other and to ensure that they get necessary treatment. So I really appreciate what you're doing, and maybe we can interact more off once we are off this program. So in terms of, in fact, I like your first question too. Isn't bipolar type 1 sometimes wrongly diagnosed as bipolar type 2? And I think that's a very, very important question. As clinicians, most of the time we tend to see patients with very severe form of bipolar disorder. So the patients who come to us have severe mania, aggressive, agitated, will be brought tied sometimes by family members. And also a lot of times we see patients with depression who have a moderate to severe depression. But there are a lot of patients who develop only mild mania. They don't become so agitated or aggressive. And the depression does not go beyond mild to moderate depression. And these are the patients with bipolar disorder who can tend to get lost between the gaps. So that neither do they understand that they have bipolar disorder, nor do they come to us for treatment. And more often than not, they tend to get misdiagnosed as borderline personality or cyclothymia or ADHD. And they go through years of incorrect treatment before they reach the clinician who is able to make a diagnosis of bipolar 1. And more often than not, only after this patient has developed a very severe episode of mania, when the diagnosis is no longer in. So this is just what I wanted to add to what Dr. Mishra has already answered very well. In terms of your question, does comorbid OCD with bipolar disorder present challenges? Yes, it does. You already mentioned it. So the thing is that OCD seems to be the most common anxiety spectrum disorder that occurs with bipolar disorder. And a lot of times they tend to run a parallel course. More often than not, we see that when the patient develops mania, the OCD symptoms tend to come down or go into the background. Whereas when the patient has a depressive episode, the OCD symptoms tend to become much more severe. The challenge lies in treating OCD symptoms that persist when the patient has recovered from a manic episode or from a depressive episode. As you rightly mentioned, the standard treatments that are available for OCD are always used in very high doses and at higher doses than what you would use them for treating depression. So the risk of switch is inherently high when you treat OCD with the standard anti-obsessional agents. So that's where I mentioned in my presentation that when you're going to do this, you have to be absolutely sure, doubly sure that you're using a very adequate dose of a mood stabilizing drug. I would probably not hesitate to even add another mood stabilizing agent, particularly if I'm going to be treating OCD with the standard anti-obsessional drugs. SSRIs are the drugs that we would probably try to use as much as possible. Clomipramine, while it may be a gold standard for treatment of OCD, may not really be the best choice in a patient who also has comorbid bipolar disorder. The evidence in terms of drugs that are available to treat are very, very limited. In fact, CanMed guidelines would tell you that after 2012, there have not been many trials on OCD and bipolar disorder comorbidity. So clinicians are left to tear their hair, and patients are left to suffer with this very, very disabling condition. But all the drugs that are available, I think there is some evidence for lithium, there's some evidence for risperidone as an add-on treatment. There is a little bit of evidence for quetiapine. Again, all of them are level 4 evidence, anecdotal reports and case series. We don't really have RCTs or meta-analysis which has looked at this particular thing. I think there is one particular study that has looked at topiramate as add-on treatment. Then you have studies which have looked at ECT in the treatment of OCD with comorbid bipolar affective disorder. What we have seen in the recent past is the use of TDCS. And when we use TDCS for OCD in patients who attained remission from bipolar, we found remarkable benefits. And there's this And probably Shriraj would be able to share that a little better. This is protocol for TDCS in OCD that has been used. And we found that a lot of patients with resistant bipolar disorder who finally remitted with closer pain, but then that resulted in worsening of their OCD and actually responded quite well to TDCS. There are 2 or 3 patients who did that. So that's something that is there, which I think can be used. And the risk of switch with TDCS is probably not as high as was once thought. So when guidelines don't give us information, we have to rely on each other's clinical experience to see how best we can help our patients. And I think that is something that I would recommend very strongly, that TDCS is something that can be used. TMS did not find that degree of benefit. I think the supplementary motor area stimulation was tried with RTMS, but it didn't really work as well. I think now there's an ongoing trial where they're looking at using the H7 coil for treating OCD. Hopefully, I don't know whether it would also be useful in patients with bipolar disorder who have comorbid OCD. So, thank you.
Thank you so much for the elaborate answer and for the encouragement about our community work, Dr. Appreciate it. Yeah. Thank you. And thank you, Dr. Mishra, as well for your answer.
Welcome. Thank you, sir.
Dr. Shantanu,
yes, sir.
I had one question for Dr. Muralidharan. Actually, regarding the findings of the study related to the use of SSRIs or bupropion that reduces the recurrences of development of depressive episodes during the course. So the question was related to the findings of the STEP-BT study related to the use of antidepressants, evidences for the use of antidepressants in bipolar depression versus what interesting findings we have got from this study, what Dr. Muralidharan was mentioning about. So how do we actually translate these those two contrasting findings? So in a real life situation.
Thank you for that question. Very important question. I think one of the things that we learn from research is to try and take earlier studies and then see how we can improve upon the methodological shortcomings of the previous studies so that we can get better informed results. So the STEP-BT study that was done earlier, I think Dr. Liatham had reviewed it fairly extensively. And what we tried to do was we tried to look at where there were methodological shortcomings. So one of the things that I did mention in my talk was the dose of the mood stabilizing drug that was used. And I think that is something that was paid a lot of attention to even at the protocol stage. And the pre-antidepressant investigations was again something that was investigated fairly in depth in this particular study. So most of the patients had to undergo elaborate, blood tests where we looked at thyroid function tests, where we looked at vitamin B12 levels, D3 levels, anything that could contribute to symptomatology as well as daily recovery. And the next thing was that there were very, very stringent criteria in terms of the dose of and the mood stabilizing drug. I don't know if I should be using the word mood stabilizing anymore. Prophylactic agent that are available. So that's where the criteria was like they should be on at least 600 milligrams of quetiapine. The serum lithium should be at least 0.8 milliequivalents per liter, and it was done more frequently to make sure that compliance is maintained and the steady state concentration of lithium is maintained. Valproate, when it was used, we tried to use it at 20 to 40 milligrams per kg body weight. The reason why these became important was that we find that in actual clinical practice, we don't really use these the kind of doses that guidelines actually recommend. So here we had to make sure that all these were there so that we actually measure what the antidepressant is trying to do, rather than always have this doubt that yes, maybe this was causing the effect or this was causing the switch. So I think the inclusion-exclusion criteria were taken from some of the shortcomings of the STEP-BT study and modified so that the outcome can be measured in a more meaningful way. Yes, of course, we still did think that our findings may replicate what they did, or we may find greater incidence of switch, particularly since we were looking at a 52-week maintenance dose of antidepressants, but looks like if used judiciously along with mood stabilizing drug adequately, there seems to be a good role for antidepressants in preventing any mood episode, specifically depressive episode. Incidentally, I think only today we finalized the manuscript and hopefully it will be available for publication sometime shortly. Thank you so much for asking.
Thank you.
Sir, there is a small announcement. Due to shortage of time, sir, what I will do is there will be 3 award questions which has been selected by our speakers, some of the jury. So we'll take those 3 questions, 4 questions actually, out of which 3 are the award questions, and then we will end the program. And what we will do is there are a lot of other questions which we will send to the speakers so that when they answer at their comfortable time, we will share that answers to all the participants of the program. So yeah, over to you, Shantanu. There are 3 awards, one for Darul, Tanu, and Udayan. So these are 3 award winners. So there are 3 questions for awards, and congratulations. And I would request Shantanu to ask these questions from these 3 participants.
Yeah, Dr. Narasimha. So, okay, so we have question from Dr. Tanu. Yeah, I think this question I should ask Dr. Murali sir to answer this question. The question is, when do we stop treatment in a single episode of bipolar depression with high risk factor, and also when there are 5 episodes of bipolar depression? The same thing, when we stop our treatment. And when do we decide that the patient needs a lifelong treatment or maintenance treatment for long? Over to you, sir.
Thank you. No wonder that got the award. So these are very difficult, but actually real life questions. See, in terms of evidence for prophylactic treatment after a single mood episode, it tends to be a little different for, say, a single episode of mania versus a single episode of depression. I think when there is a first episode of mania, we are not in any doubt about what the diagnosis is. And we know that irrespective of what the future episodes are, the diagnosis will always remain bipolar affective disorder. So the question then is that, when you decide if somebody needs a lifelong treatment or not, and a lot of times it's the indicator of severity that determines whether somebody needs lifelong treatment after the first episode of mania. So the indicators of severity would be requiring hospitalization, presence of psychotic symptoms, and probably requiring ECT for treatment. So these would probably guide you in deciding that, yes, this is a patient who's a candidate for lifelong treatment. Whereas people who do not have this have milder mania, more. So you would decide that, yes, you could give a trial of discontinuation and informed decision and then restart if there's another episode. Whereas when it comes to bipolar depression, a single episode, the challenge as a clinician would be to convince the patient that probably they need lifelong treatment. So Dr. Mishra mentioned very beautifully what are the features of bipolar depressive episode vis-a-vis unipolar depression. But then let us remember that these are not absolute. There are always overlapping features. The patients with bipolar depression may have features suggestive of unipolar depression and vice versa. When you have a patient with a single episode of bipolar depression, like I just mentioned, we may have to continue treatment for about 6 to 9 months. And after that, it finally comes down to engaging the patient in treatment. And you have to take, I think, establishing rapport, ensuring that they continue in the treatment process, remain adherent to treatment become far more important. But then the decision to continue lifelong treatment is something that has to be taken in discussion with the patient. Whereas after 5 episodes, there's no question at all. If somebody has had 5 episodes, then you know what would be the drug of choice for this particular patient. Most likely it would be quetiapine or lithium. And the manic episodes in that case become incidental because the number of depressive episodes have been that many. So that's what I would say. In a single episode of bipolar depression, while there may be a lot of overlapping features between unipolar and bipolar, somebody who's had this episode very early has abrupt onset, acute onset of symptoms, psychotic symptoms, catatonic features. You know very well that this is bipolar depression. You would still probably wait a little bit before you could decide on lifelong treatment. Whereas if there's more than one episode, then I think prophylactic treatment with a mood stabilizing drug becomes paramount importance. And after 5 episodes, there should be absolutely no doubt. Thank you.
Thank you, sir, for the answer. I think, Dr. Tanu, you have got your question answered. If you have any issues with the question, anything that you found that you need to clarify, you can put down in the chat box again. So we go to for the next question. This question I'd like Sai sir to ask to answer this question. It is from Dr. Umesh S from CIP Ranchi. So sir has asked a question: whether can we expect morphometric changes in adolescents and youth with bipolar disorders? To Sai sir, Dr. Sai Krishna Tikka sir.
Thank you so much, Umesh, for this question. Like I've told you, that if the onset of illness of bipolar depression, depression which is more bipolar-like in adolescence itself, then definitely yes, we are going to see morphometric changes that we should expect them. They it may not be in the areas that we classically know of, say for example hippocampus or in the cortical areas. But I guess if we are trying to analyze a lot of other areas, I think some of the areas that definitely will have morphometric changes. If this is specifically in the context of if the onset of illness is during adolescence, because it is understood now that it's more of developmental in nature, and these deficits predate the onset of illness. So yes, my answer will be yes. How definitely? I mean, that is up to that particular area that we are looking at. The other areas that we are looking at is.
Thank you, sir, for clarifying this. Next question we'd go. It's an interesting question. So, from Dr. Udayan Bhagat, second question from him, I suppose. So he asked about considering ketamine's NMD antagonistic activity. Should we consider subanesthetic dose of ketamine infusion in bipolar depression, as there's an increased chance of causing de novo psychotic features or a switch? Morley, sir.
Yeah, thank you so much for that question. First of all, I think the point that I would want to consider as a clinician is, does this patient require ketamine? So if somebody is requiring ketamine, it means I've exhausted all possible armamentarium treat drugs available in my armamentarium, or that this patient is probably not a candidate for electroconvulsive therapy, because first of all, you're using a drug which is not primarily an antidepressant. It is known to have more acute benefits, whereas the long-term benefits of ketamine are not really well known. So the relative, risk versus benefit ratio for ketamine is probably very, very low. The risks outweigh the benefits, and there are no long-lasting benefits. So yes, if you've exhausted most of the other treatment options, if your patient is not a candidate for ECT, then you could probably think of this particular option. But let me tell you, in a study that we did at NIMHANS, and some of my colleagues have done that, we didn't find much difference between ketamine infusion and ECT in terms of their time to response and remission. In fact, I think probably they required one less session than ECT, which was not statistically significant. So when you look at those kind of features and those kind of data that we have, the question that we need to think of is, okay, I'm going to give ketamine. I'm going to try and bring about an improvement in the depressive episode. But how long is this improvement going to last? Right. So when you think of that, then probably you're going to look at a lot of the other treatment options. So yes, while it can cause benefits, it can help in patients with bipolar depression. It is something that I would keep very, very low on my priority list. And in a patient whom you're prescribing ketamine because there may be suicidal risk, don't think beyond ECT at all. So, thank you.
Thank you, sir, for the question. I think, Dr. Bhagat, you got your answer from sir. We'll take the last question. I would keep this question open for our three esteemed speakers. This question is from Dr. Darrow. She asked, most guidelines include olanzapine fluoxetine combination, and whether there is any particular ratio of olanzapine and fluoxetine in this fixed drug combination. As we know, it might be 6.25 plus 25, and then the other dose. So, is there any fixed ratio for this combination of OFC? And second question is very interesting, like why only olanzapine and fluoxetine? We know that there are other antipsychotics which have as well mood stabilizing properties like aripiprazole, quetiapine, etc. And why not we give a combination with other SSRIs like escitalopram plus quetiapine, escitalopram plus aripiprazole, etc. And also, the question continued like this: in elderly with many comorbidities with like diabetes mellitus, CKD, what would be the rational choice for treatment? This question is open to all our speakers.
I
Yeah,
think
for
I've been speaking too much, so I'm going to let the other speakers answer.
yeah, please carry on, sir.
No, I said I have spoken too much already, so I'm going to request you to answer.
So
So-
related to the choice of like the treatment choice in case of elderly with comorbidities, definitely as we take these two options of lithium and quetiapine as the first line drugs with the highest level of evidences for in both the acute phases as well as for maintenance in bipolar depression. Incidentally, what happens is after age of 65 to 70, as a natural process, the glomerular filtration rate, the GFR, reduces as compared to younger individuals, and elderly more than 65 years, the GFR naturally reduces. So continuing on lithium will not be a clinically good choice, looking at the possibilities of the adverse effects and the nephrotoxic effects and the fluctuations in the pharmacodynamics related to the maintenance of the serum lithium levels. Again, quetiapine, the dosage which is recommended for bipolar depression in the range of 300 to 600. If you go on a start at that dose, in elderly individuals, you have to be very cautious regarding the issues of postural hypotension, falls, and drops. So these are very tricky issues where like the choices of drug has to be, so every drug will have some adverse effect or other, but we'll have to take the risk benefit ratio rather than going strictly by the guideline. We have every treatment has to be personalized according to the patient's physical comorbidities taken together. There is nothing like we have an absolute answer, a uniform answer for everyone. So I won't mind giving olanzapine fluoxetine combination if in elderly with bipolar depression, where I suspect that the GFR will be reduced and there are issues of fall and postural hypotension. I won't mind choosing OFC, even if I know that there is a risk of metabolic syndrome with the use of olanzapine. I will rather prefer it over the other two agents. Again, it will depend upon how the body responds to the individual drugs, like how the body responds to higher doses of quetiapine and all. So it will be an individual choice depending upon the patient's profile.
Thank you, sir, for the answer. And other two questions from from him is that whether is any fixed ratio of this combination. As we frequently prescribe, it is olanzapine fluoxetine combination ratio of 5:20 or 10:20. So any consensus over to the speakers? And if other combinations of antipsychotic plus SSRIs are feasible till date, because we have only olanzapine and fluoxetine for us for bipolar depression.
You have picked, you like
yeah, Murali, sir.
Dr. Sai Krishna, please.
I'll take up the second one. I guess the fixed ratio combination, I think I'm not very sure about that. But when you tell me about other drug combinations, although there are no fixed drug combinations available, but then in general use, it's quite common for us where we start them when the moment we see that it's bipolar depression. There is a mood stabilizer, there's an antipsychotic case. But then in cases where someone is not tolerating mood stabilizers well, or there's still depression going on, then we tend to add other SSRIs too. So there is combination of antipsychotic and an SSRI or any other antidepressant being used there, but although they are not available in fixed drug combinations, but yes, we are using it in our daily practice, and there is good amount of chance that they will respond also to that. But why it is not there is not, that I think that answer will be for for someone else, not for us. And I think for the fixed the drug ratio combination on olanzapine and fluoxetine, I want others, either Mishra sir or Muralidharan sir to answer.
So I think the olanzapine fluoxetine combination, if you look at it, look at the study that was done, I think the comparator molecules were olanzapine, fluoxetine, and placebo. And though olanzapine did, separate from placebo in terms of the improvement in depressive symptoms, the difference was much more on a combination of olanzapine and fluoxetine. The reason why that combination was chosen was probably because they tend to have, this effect on each other's metabolism. They inhibit each other's metabolism so that the bioavailability of each drug tends to be that much higher. And the combination of these two was shown to prevent meaning switches. So that was the reason why that combination was used. And it was used, olanzapine was used in a little less dose than what it was used alone. So 5 to 10 milligrams of olanzapine and 20 milligrams of fluoxetine. So that's the ratio in which it was used. Whereas if you look at olanzapine that has been used in anti-manic trials, you'll find that it's used in doses between 5 and 20 milligrams. So the dose of olanzapine in this combination is a little less than the anti-manic dose of olanzapine, whereas the fluoxetine dose is 20 milligrams per day. And we all do know that if somebody doesn't respond to 20 milligrams a day of fluoxetine, it's unlikely to cause improvement at 40 milligrams per day. So that's the rationale why olanzapine 5 to 10 mg plus 20 mg of fluoxetine was used. And that combination was found to be far more effective than using olanzapine alone. And the risk of switch was not much different from placebo. Regarding why other combinations are not there, no trials have been done. So only this thing has been tried. So whatever we are doing, I think it will finally come down to clinical practice, because it's simply also, I think it's going to be a little difficult to get ethical approval to do a study like that. When you already have a drug like quetiapine, which has been shown to be effective in treating bipolar depression and preventing bipolar depression, what is the rationale for adding escitalopram, where by not increasing the benefit, you're actually increasing the risk of switching? Okay, so I think it is going to be a little difficult. Except if you're going to add escitalopram after you've given quetiapine for a sufficient period of time and found that there is insufficient response to quetiapine alone, right? But to give it as a combination probably is not something that you would be able to get ethical approval to study. So it finally comes down to how you're using it in clinical practice. There also, I think the key thing that we need to remember is before we add escitalopram to quetiapine, it's important to see what the guidelines have said. So guidelines have looked at quetiapine. The evidence says that quetiapine at 300 mg and 600 mg is far more efficacious than placebo. So if you're going to start somebody on escitalopram, you should make sure that we've tried quetiapine at least 300 mg or about 600 mg or maybe more, even more if required, before you decide to add escitalopram. So the combination may work well, but I would prefer to add escitalopram after I've tried the patient on 600 milligrams of quetiapine and find that there is inadequate response. To augment the response of quetiapine, I would probably add escitalopram, but it's not possible to do studies like that. So even in the study that we did, we had an open label phase where the patient was already on a mood stabilizer to whom we added escitalopram or bupropion, because the treatment, the response to the mood stabilizing drug alone was inadequate. Thank you.
Thank you, sir. So I would like to take the privilege to give my vote of thanks for this program. First of all, I should thank our speakers, B.R. Mishra sir, Muralidharan sir, and Sai Krishna Tikka sir for agreeing to talk, and the level of engagement of all the audience throughout the program actually tells us that how successful this program is. So 3 hours on a Saturday evening, being engaged, and almost for throughout the program, the number of participants were 50, and even at the end of the program, the number of participants is more than 40. Meanwhile, I would also request everyone to keep their videos on so that we can have a group photo on the WebEx platform, so that we can have our happy faces at the end of the program. If whoever are participating, if they can switch on their videos. Meanwhile, when I give my vote of thanks, Shantanu, would you like to take the photos through screenshot?
Yeah, Dr. Narasimha.
Yeah.
Yeah. Now I can see many known faces. I can see my friend Dr. Diptadi, Dr. Tanu. I can see who asked one of the award questions. Dr. Pankaj, my friend from Varanasi. Surjit sir, Umesh sir.
Wow. So many.
Uh,
So
anyone to
participating
switch on
in
their
the
videos
program.
so that I can take a photo?
Yeah. Okay. So meanwhile,
Yeah.
I will also continue my vote of thanks. I would like to thank IPS Jharkhand State Branch, President Bakla sir, Varun sir, Saurav sir, Surjit sir, for the opportunity for us to actually organize this program. Without you giving us the opportunity, we would not have organized such a wonderful program. I would like to thank our ED sir, Professor Saurav Varshney sir, and my institute for giving me this opportunity, giving us the opportunity, the department, for organizing this program. I would like to thank the CAP team for giving us the WebEx platform to conduct this program. I would also like to thank the IPS East Zone, Madam joining from IPS East Zone, and giving her remarks in the beginning, and always the continued support of IPS East Zone, and the participants, the excellent enthusiasm of all the participants. I think after in the last 2-3 years, this is the best participation I have seen in an online platform for such a continuous duration, and the questions that they have asked. And congratulations to the award winners, Darul, Tanu, and Udayan. And I would also like to thank our extreme chairpersons who has been supportive to for all the sessions. And I would like to thank each of us, me and Dr. Shantanu, two people in the department, for organizing this program. If I have forgotten anyone, maybe Shantanu, you can tell me.
Yeah.
Did
Yeah, I
forget
think
anyone?
Narasimha, we have tried to cover everyone.
Yeah.
And also much help from CIP Ranchi to get this link, this WebEx of this WebEx platform. Actually, it was a discussion amongst us how to host this. So we got this ready help from CIP Ranchi, this WebEx platform. We should thank also.
Yeah.
Thank you.
Thank you, everyone, and have a wonderful weekend. We will send you the certificates through a Google Form link, maybe in a couple of days, 1 or 2 days. We will share